Welcome back to the AATS Mitral Conclave 2015. I'm thrilled to be joined now. I think I'm thrilled to be joined by Dr. Steve Owen from Michigan, Dr. Joe Wu from Stanford, and Michael Acker from Philadelphia. Mike, thank you all for joining us. So, a topic that I know neither of you have ever talked about or written about, ischemic mitral regurgitation. Where do we stand now in our understanding of how to treat ischemic mitral regurgitation? Who wants to start? Joe, you want to start? Mike?
Why don't we have Mike start?
Since Mike's got the paper, I got his paper.
Well, there's actually two papers with ischemic mitral insufficiency that we sought more evidence in the Cardiac Surgical Network, designed two randomized trials. First question that was very vexing for us clinical surgeons was what to do with moderate MR when patients are undergoing coronary bypass surgery. Do we put a ring in or don't we? Not a lot of evidence on that in a randomized fashion. And the second trial that was maybe even more controversial is what to do with severe MR. Do you repair it or do you replace it?
Correct.
And there was a randomized study there also, and we have some evidence in those two areas. To summarize, in the first trial, moderate MR, putting a ring in did not affect reverse remodeling at 1 year.
If you revascularize.
Along with CABG.
Right.
There was no clinical difference between the two groups at 1 year, but there was a significant increase in moderate MR at 1 year if you did not put the ring in.
Okay.
The second trial on severe MR showed that whether you repaired or replaced at 1 year, again, no difference in reverse remodeling. Both groups got better.
Right.
No clinical difference between the two groups, but yet a marked increase in recurrent MR with repair versus replacement. I guess those are the summary of it.
And that generated a few comments. Just a few comments.
Yeah.
Before I get to Steve, Joe, what's your take on both aspects of that?
Right. Well, the two trials actually, in some regards, showed results that were somewhat opposite of what you expected. The classic thinking, at least in the severe ischemic mitral regurgitation trial, was that doing a mitral valve replacement was riskier than doing a mitral valve repair. And that was based upon historical evidence showing a higher rate of morbidity and mortality with mitral valve replacement than mitral valve repair. Looking back, we realized that most of those studies were looking at highly selected populations and really comparing apples and oranges.
Right.
And that it was very interesting to see that mitral valve replacement did not result in any increase in adverse outcomes for the patients compared to mitral valve repair. In terms of the long-term follow-up, short 1 year follow-up, it was not surprising to see that there was not recurrent regurgitation in the replacement group. It was interesting to see the extent of regurgitation in the repair group. 32% was probably even higher than what was expected and what was shown in other studies. So the difference in amount of regurgitation at 1 year was pretty striking. And the sort of general clinical conclusions that one can take away from that particular study is that in certain patients, it may not be inappropriate to replace them up front, to go right to a replacement strategy.
What do you think?
So I agree 100%. I think there's really a paucity of data in this field, and these were superbly done trials, and everyone involved with the trials should be congratulated. The moderate trial was the most interesting to me in that there was no mortality benefit, but there was no mortality ding. So to add a ring didn't change operative mortality. You would think that would add some risk, but it didn't really. It added some. Of course, their AFib rate was higher. The interesting thing was that a year, 30% of the people without a ring had significant mitral regurgitation. The problem with these patients, as you know, is they're not like TAVR patients. It's not a mortality concept. These are patients who do poorly, slowly. So I think Mike would agree it's going to be very interesting to see what those patients do. Is there a balance between put a ring on it, Beyonce it, and how are they going to do those patients who have residual moderate mitral regurgitation over the next 2, 3, 4 years? The severe trial, also interesting in that really, I agree with Joe 100% that our intuition was you should repair them all. The replacement was very dangerous, and that turned out not to be it. But it looked like, to me, that there were probably ended up 3 groups of patients in this trial. Good repair, where they didn't have very much recurrence of MR. Replacement, which of course they had no recurrence of MR, but you have a replacement device, and then somehow not well done or bad repair where you got a lot of recurrence. And it's interesting, the follow-up paper by Dr. Crone in the JTCVS really showed that those patients who had a good repair got good remodeling. They probably did the best of all of them. So I think there's a lot of data in these trials, and I think the question is not whether we should repair or replace, because clearly there are some patients who you need to replace in this group. And they may be the ones with reverse angulation or association with a basilar inferior aneurysm, or those patients who have their distraction longitudinally, or they really don't have very much annular dilatation. And I think it still remains, that good repair is probably the best. The question is, can we get everyone there? And if we risk a bad repair for a patient, that's probably a bad outcome.
Yeah, I think what it really shows, well, as Steve said, replacing a patient with a severe ischemic MR is fine. It's okay. You're not hurting a patient. And I think in the past we felt we were bad surgeons.
No, I think that's a good.
But more importantly than that, we need to be able to predict, as Steve already said, who's going to get a recurrence, and tailor our operation specifically to the patient's preoperative characteristics and not lump everyone together. As far as
do you have an opinion of who that is?
Oh yeah, I think as Irv Krone's follow-up paper and some of the more work coming out of the Gorman group and stuff like that, it's no question the severe tethered, the huge ventricles, the basilar aneurysms, the ROC curves, which are more complex that the network has developed as a pretty good 80 to 90% prediction. But equally interesting isn't turning around that moderate paper.
Right.
70% of those patients that just got revascularized their MR went away. How do we predict that?
Well, I think
that's pretty interesting.
That is a really good, interesting
Look at the other point.
Because the viability in those patients,
we don't know. Right?
We don't know.
We didn't,
and so we didn't measure it, so we don't know. Were there people in that group who didn't need a ring? So I think we have to work through more identification. In the moderate group, it's interesting, whether you had a ring or not, if you were left with no or mild MR, you reverse remodeled. And if you had severe MR, whether you had a ring or not, if you ended up with severe MR, you kept remodeling the wrong way. So I think this is really one, in a randomized prospective way, it shows that MR is bad for these patients.
But yet it doesn't show that it's correction. Well, with the exception of the repair group. It does. There's no question what Steve said. The best thing to have was a repair with no recurrence.
Right.
But is that because you got rid of the MR or because those ventricles were different to begin with, right?
So again, when you think of these papers, do you think, are these the answers? No. I don't think that answers. They bring up a lot of data and generate good questions.
Joe, what are your thoughts on it?
I just think, speaking to Steve's point, there's something about the biology of the ventricle that we need to figure out. We need to find some sort of preoperative imaging modality that integrates MRI, perfusion, echo, a variety of technologies such that we can determine whether or not that ventricle is going to improve or worsen regardless of what we do to the mitral annulus.
Correct. Well, I mean, but you in the argument that it's obviously a ventricular problem, but there are, many people have talked about, how big's the tending distance, what's the tending height, what's the angle supposed to, all those. Is that stuff important? Equally, it's not equally as important as to the burden on the ventricle. I mean, the ischemia of the ventricle.
It is a ventricular problem. I think all of those really have to take an integrative approach. In the severe patients, we want to end up with 2 groups. We want to have 2 choices, good repair or replacement. And we don't want to have a group patients in this third group, bad repair.
And then
that doesn't help anybody.
And it opens up the field of, obviously, the simple repair that Bowling talked about, now going on 20 years ago, isn't so simple. And if we're going to repair this group of patients, we're going to have to address the subcortical apparatus and the tenting directly. But that's not necessarily better than just doing something simple like replacing. So that's another study, if you will.
You know, it's so. Joe, in the current state of affairs, if you're operating on somebody who's got, you know, ischemic MR and it's moderate MR, what are you going to do?
My tendency would be to repair that.
Okay, you're going to revascularize and compare.
Revascularize
And you're going to
repair.
use what, a rigid ring, an undersized ring?
Typically a complete semi-rigid ring
Okay.
with a focus on reducing the septal lateral dimension.
Correct. Okay, so is that
I think
right?
I think that's one thing that you can take from these papers, that if you're going to repair, you should use, in this group of patients where it's a ventricular disease, a small, complete rigidity ring. And if you're going to replace, you need to do total cord sparing replacement.
For sure.
Okay. Now, the last thing is, so then you've got somebody who's got pretty significant MR, okay? And, you know, you're getting ready to revascularize. They got severe MR. What are you going to do?
I think in those patients, there is a certain percentage, and I do not know, 10% that we should replace, 15% that we should replace based on their echo findings. Tenting, distraction, posterior displacement.
So you're going to think
minimal.
about replacement.
I think in some patients, yes.
Is that a percentage sound right to you, or are you going to think about it in more percentage, greater percentage?
I would say that in the older patients and those with very large ventricles, I'm going to be thinking much more aggressively about replacing. As
I mean,
opposed to trying to
the reason I'm raising that question is so if you guys are all very talented surgeons, but you get somebody who's maybe not as talented, they've done a bypass, they do one thing, they come off and they've still got MR, now they got to go back and do a replacement in a sick ventricle.
Well,
is that an argument or
the
not?
The issue isn't what happens. If you put in a small ring, the MR initially will go away. It's about recurrence. And frankly, I worry about the inexperienced surgeon replacing the valve quickly with retaining all the chordate more than putting a ring in. Putting a ring in is easier. Don't you
Technically,
think, Joe?
putting
I
a
mean,
small,
do you
complete
think
ring
it's-
in is less technically
But
difficult. But
I'm not.
You don't know?
I'm not a surgeon, but
Yeah, I think it can go both ways. I think that the majority of ischemic mitral regurgitation can be repaired relatively easily with just a ring.
Correct.
And then there's a small percentage where there's so much tethering or there's something else going on that you haven't recognized. You put in the ring and you're assuming it's going to work, and all of a sudden you're looking at regurgitation
what
right
is that
there.
percentage?
That's
11%.
I think
low.
it's higher.
Intra-op, that's low.
Interop's low, but you asked him,
I don't know
Steve,
what
what
the
the
percentage
percentage he would think about replacing. At least based on the study of the 30 to 40% recurrence.
Correct.
At 1 to 2 years, I would say 30-40% of the
40%.
patients should get replaced.
It's interesting,
But
though,
how
that
to pick that out?
contemporary studies done at the same time in different countries had a 4% recurrence rate.
Not
or
for
a
severe
5%.
MR.
Mixed bag, I agree.
There is one other small issue.
Okay.
If you find that you have a relatively smaller annulus compared to your typical large dilated annulus in ischemic mitral regurgitation, and you have a person with a large body mass index, and you're thinking that you're going to need to put a very, very small ring in there to eliminate the mitral regurgitation, that's a person that may be predisposed to dynamic mitral stenosis
Absolutely.
later on down the road.
Absolutely.
And someone that you might lean a little bit more towards doing a replacement.
I just saw a patient that had exactly that a year out from got resting mean gradient of 11 and went to, with low level exercise, went to 20 with a very small
You know, the
raise.
work coming out of Italy with Magni's group is
It's pretty.
it's consistent and a little, it makes you question what we've been doing.
All right.
So, Randy, if I could just say one comment. I saw the person who presented the severe mitral regurgitation trial, the so-called Acker trial. It was Mike Acker. And they asked him the very first question after the Acker paper had been presented by Acker. They asked him, Dr. Acker, does this mean we should replace them all? And Dr. Acker said, No, it doesn't mean that.
That's true. I said 30 to 40%.
34, exactly.
All right, well, as you can see, we now have total clarification
Yeah,
on this
absolutely clear.
issue. I am very clear now. So when they called me from the OR and said, what should I do? I'd say, call Acker,
Yeah.
Bowling, or Woo. It's
There
a
you
law
go.
firm. Thank you guys very
Thanks for
much.
having us.
Thank you.